Alrighty, let's pick up where we left off. Just the first page is that we're going to talk about postprandial hyperglycemia. It's a little bit of a hallmark of GDM because we don't do it in med-surg. Now, if you recall in med-surg, on the floor, you usually take the glucose level before his breakfast. Do you remember that? And depending on the sliding scale, if he has a certain value of glucose, then you have to see if you give the insulin. Well, we do not do that in OB because you'll see why below. The physiology is different. In OB, what they do is after she's had her breakfast, let's say, she's going to have what we call a 1-hour postprandial glucose check because we know glucose rises 1 hour after her meal, after prandial's meal. So we'll take it 1 hour after she finishes. We ask the mom saying, can you let me know when you finish breakfast? Because then I'm going to come in 1 hour afterwards and get your glucose level. And that is normal. And then we'll check them. They have a sliding scale. And then we'll give her glucose if it applies. It tends to disappear after pregnancy. We'll understand why in a minute. Risk factors is greater than 30. She has a higher BMI. A big risk factor is a family history of type 2. Baby tends to be low macrosomia, LGA. Unfortunately, some babies come with congenital abnormalities, which we'll talk about. Polyhydramnios, unexplained stillbirth, or SABs, spontaneous abortions. We'll talk about that in the third page. If you see here, it includes some use or no use of insulin. Some of the moms are just on oral hypoglycemics. Some of our moms are just simply on diet control. Diabetes tends to persist after pregnancy, and that is now up to 70% chance of getting type 2 after pregnancy. The percentage is going higher, unfortunately. And that's a little scary. 70% is pretty high. Now, I'm going to go slow here because I want you to differentiate what's going on in OB. Pregestiral diabetes mellitus is when the mom has type 1 or type 2 before pregnancy. I just want to differentiate them. But I wanted to highlight this. The physiology is now from this point below and on this page. Let's go nice and slow. Make sure you understand this. It's a little different from med-surg. Maternal glucose. Let's say she eats a big old 4x4 hamburger at In-N-Out. She loves hamburgers, right? Who doesn't, right? And all of that glucose rushes through the placenta. The glucose diffuses to the baby. It's free reign. The body's thinking, which is the mom's body's thinking, I want it to give it the abundant amount of glucose possible to the fetus to help him what? Live, survive. Well, that makes sense, you say. Okay, I get that. However, the opposite happens in that when she eats her 4x4 from In-N-Out, maternal insulin rises in her. However, it does not cross the placenta. There's no transplacental diffusion because the baby makes up his own fetal insulin for the rise in glucose. And you're thinking, oh, why? Always ask why, right? One, Mom Nature wants to have an abundant amount of glucose going to that baby for survival. However, if the mom insulin crosses over and his insulin is also produced, he's going to what? He's going to bottom out. His glucose is going to totally drop and he'll be hypoglycemic. We don't want that. So what are we going to say here? Babies in utero can face mild to moderate glucose changes. What they cannot do well in is an acidotic environment. So when we have glucose going a little bit up and down from mom, the babies tend to tolerate that. What happens is if she has total noncompliance and she even comes into like DKA, that acidotic environment, acidosis obviously goes to the baby. And he has a very difficult time with acidosis. Okay, so just kind of review that and make sure you understand that. Let's track it through first trimester, second trimester, third trimester, birth, and breastfeeding. let's talk about the physiology. Okay, let's say she's pregnant right now, first trimester. And we know in prenatal lecture, estrogen rises, progesterone rises, and her maternal insulin production rises. She becomes what we call increased peripherally sensitive to glucose use, meaning what? Her body's super efficient. She efficiently uses glucose because insulin is super, super efficient. Remember the keys? Allowing the fat and the muscle cells, it opens up the fat and muscle cells, and the glucose goes right in. She uses it so efficiently that sometimes her glucose drops, right? Her glucose level drops. Sometimes also plus, she gets nausea and vomiting from what? Morning sickness, so her food intake drops. So her fasting glucose level tends to be lower than med-surg. Now remember, med-surg, normal med-surg glucose level, depending on the hospital, but typically it's 70 to 110. 70 to 110 is normal glucose level in med-surg. Think of it looking at both the ends of 70 to 110. In terms of OB values, fasting glucose for moms is on the low end. It's 60 to 90 milligrams per deciliter is normal fasting glucose for mom. So we want to remember that. So what happens? Her body's so efficient with the insulin. The keys are so efficient. Insulin need, therefore, insulin need is what? Decrease. And she tends to be more prone to what? Hypoglycemia. Now let's look at the second and third trimester. What's really happening inside her body? The key is that the placenta is getting bigger. And because the placenta is getting bigger, it's liberating a lot more what? Hormones. Human placental lactogen, estrogen, progesterone, prolactin, cortisol, and look at this big one, insulinase. ACE is a what? Enzyme. It's an enzyme, which is what? An insulin antagonist. You're going, why? Why does it want to decrease insulin, the keys, usage? So what happens is when she has insulinase running around all in her body, that she doesn't have as many keys, or the keys, which are the insulin keys, are not as effective. So what the word is, she has decreased glucose tolerance, meaning she can't tolerate eating 2 4x4s and in and out. Not like before, right? Because we don't have enough keys. So her body becomes very insulin resistant. It becomes resistant to insulin, the use of insulin. So this is a glucose sparing mechanism for, and I want you to write it in, it's a glucose sparing mechanism for baby. It's very, very important because, you write in baby or fetus, because in a sense, Mom Nature's super smart. She's letting the baby grow and allowing what? The abundant amount of glucose going to baby and not what? Not allowing as many keys to be effective. It increases what? The survivability of who? The baby. And that's one blank I left, so it's keep you on your toes, right? And baby, you go, oh, okay, so it's preserving the survivability of the fetus. Correct. So ... Insulin need is what? Increased because there's insulin antagonists. So she's going to have to take more insulin. For some moms in the second, third trimester, students have given up to 110 units of insulin for these moms. It's amazing. Then we have to use 2 syringes. And so therefore, ... she's more prone to hyperglycemia. Third trimester, same as second, and all the way to 36 weeks. And this is the word in the book. Not only the phrase is glucose sparing mechanism for the baby, but she's in a diabetogenic state of pregnancy. And so because of that, she kind of runs diabetic, right? And therefore, ... insulin need is what? Increase. She sometimes we order, 40 of NPH and 79 of regular, and we mix it and we give it to her. It's like, whoa. So she's more prone to hyperglycemia because of the what? Insulinase running around because of the placenta. As soon as that placenta's birth, everything drops. The placenta leaves, the hormones leave. She's in a pre-pregnancy sensitivity to insulin. Therefore, insulin need is decreased. On top of it, she's breastfeeding. Breastfeeding uses maternal glucose and also increases what? Kilocalorie burning, right? It metabolizes a lot of calories. You hear moms, yeah, breastfeeding ain't like a pig, I ain't even gaining any weight. So it's burning calories, just like when we play tennis. Therefore, insulin need is what? Decreased. You don't need as much insulin after that placenta comes out. So risk and complications. Review and signs and symptoms of hypoglycemia and hyperglycemia. That is from first semester. Let's look at the physiology of what's going on here. Always think of your physiology, and that tells you the answer. Why? And then you study and memorize signs and symptoms, because we only understand it is when we understand the physiology. If mom's running around with sticky glucose and acidotic blood, you can understand the vessels are getting more what? Narrow. So she has more of an increase of spontaneous abortions because why? Vascular is very, very poor. Vascular health. She's not getting enough O2 to the baby. And then, of course, I can understand why she's preeclamptic and pregnancy-induced hypertension, because she's hypertensive because of all that gunky glue, sticky blood. That's what? Making the vessels more narrow, right? So you see a lot more vascular restriction, vasoconstriction. And also, especially with pre-existing vascular changes. She's polyhydramnios. Think of the fluid shifts. She gets a lot more fluid on board. So she has a problem with maternal supine hypotension. She has that big gravid uterus because of the polyhydramnios, so it's pushing on the thoracic space. So she has a hard time breathing a little bit. She pops early. She premature rupture membranes because her what? The uterus is so big from all the amniotic fluid. She goes into preterm labor. She pops and she contracts because she's so big. The poor uterine vessels are what? Muscles are stretching. Then it's stretched so much, the uterus, she tends to have a problem with postpartum hemorrhage. Oh, that's a lot of problems right there. Because the poor uterus is trying to what? Contract to close off the uterine arteries. And it's so big and stretched out, the uterus takes more time to contract, to involute. Infections, remember all that sticky, sugary blood. Well, of course, it harbors what? Opportunistic infections. We see all the postpartum infections, vaginitis, UTI. And then now we have also the acid-base problems. And we have a lot of acid-base running around, acidotic blood running around in the mom. You're thinking, the baby's not going to do well. He does not do well, especially due to what we call increased stress. You put out more catecholamines, you put out more cortisol. Then the baby gets a little more acidotic, and tribulin will learn in a drug that produces more glucose. So remember, increased glucose is produced by high stress and side effect of tribulin. Sympathomimetic, what we call drug, it's similar to the sympathetic nervous system, so it's going to put out more glucose. So we see, unfortunately, more incidents of intrauterine fetal demise, more preterm labor. Over here, the poor little baby does not do well. Stillbirth, we have a lot of malformations due to the acidotic blood. We see a lot of the glucose in mom and glucose in baby, in which produces a big baby, but insulin, not glucose, becomes the growth hormone. And we're seeing more dystocia, difficulty having a vag delivery. We see more C-section babies because they're so big. We see, unfortunately, intrauterine growth restriction. You go, I thought we had a big baby. Small because probably what? The mom has been totally non-compliant, probably for a chronic period of time, not acute, chronic, for over many years, in which what? The vessels become more what? They became more constricted. The lumens are smaller, less O2 to the baby, less growth. You see more RDS because glucose competes with what? Surfactant production. So less surfactant production. And lastly, I want to just talk about how when the baby's cord is cut, his glucose drops. And he's hypoglycemic, not hypo upon birth. And that's really important because the nurse will say, watch the mom's GDM. As soon as we have the baby, we're going to have what? The glucometer ready because he's probably going to be what? Jittery. All right, we'll go to the next video.